So Easter holidays, I came back. Well, I was wrong on my Easter holidays, to be told. We had a foot of water everywhere. A sink burst in the night, and in our treatment rooms where the nurses see people, we've got a special floor that's easy to clean, but it means it's got adhesive onto the concrete. So if you get water under it, you've got a real problem because you can't just lift up the carpet and let it dry out. So we had to shut off the whole of the back of the surgery, take up the floors, the cupboards, and most of the bottom bits of the walls from the back sort of third of the surgery. We had to have drying equipment in. So that's why we've now got two extra porta cabins in the car park because we didn't have anywhere to put the staff. So that has affected some people's appointments. Um, because the porta cabin isn't perfect for everything, but we've tried to do the best that we can. Um, and the only other thing I'd say at the moment is our practice manager, unfortunately, has been unwell for the last couple of months. So again, that puts strain on the practice. But we're just trying to keep going. If anybody has any feedback or any questions they've got for me, then that would be great.
I think it's really difficult when people contact the doctors because they tend to do it when they're unwell or they're worried about a loved one. And I think therefore sometimes tensions can be really high, and they're bringing all that to the first person that answers the phone or the first person who's at desk, which tends to be our receptionists or care navigators. Some people as well don't like having to speak to reception and telling people what's wrong with them. But the idea of that is to put in place all the things that we've previously talked about to make sure you're seeing the right person in a timely manner. So I think people do get very frustrated, and the receptionists take the brunt of this. That's been a lot harder since COVID. We had to put in place certain restrictions in COVID because we were told that's how we had to work, which were really frustrating to patients. Our staff try their best, but there are times when everybody loses their cool. And I think I would say to people, we try and offer the best service we can. Our patients in this community are are usually incredibly grateful for the service that we offer, but it doesn't always go right, and it's not always in the way that patients want it to be delivered. But sometimes it is the way it is because we have no other capacity to offer it in a different way. And I would just really encourage people just to realise that the receptionist on the end of the phone isn't the person who unfortunately makes the rules. They're the person who is the first line of defence. Usually by the time I see people, they're really pleasant and nice. But it is hard. If people are shouting at you, it's really difficult to try and get them what they want, because that's when communication breaks down. And we've recently had flooding here at the practice. We've had builders in, we've had drying equipment in, so we've all had to work in a very hot, noisy environment. And that causes problems for staff who are working in that environment 10, 12 hours a day, and we all get ratty. So from time to time, it's good just to be, I think, understanding of each other. And always ask if something's not clear, if you're unhappy about something. It's always fine to raise it and address it, but try and do it in an understanding manner, I think. All our receptionists are trained as care navigators. I think the interesting thing is being a doctor's receptionist is not like being a receptionist anywhere else. It's a completely different role, which is why it's probably good that we're starting to change the name. Often people will ring when actually they should be ringing 999. And that needs to be rung for them, and they need to be told that they need to do that. The care navigators need to realise if there's somebody they should flag up to us really quickly because they're worried about how they sound on the phone. They need to try and make sure that they're with the right person and they're getting care in a timely manner. So it's quite a complicated role, and we give them training for that. And we've recently had a whole day of additional telephone training, just because it's one of those things you need to keep making sure you're reinforcing what should be done, and you've got safety measures in place, and therefore it's important we train our staff regularly for that. I've been in this practice for over 20 years, and when I first started working here, unless I was duty doctor, my days were very simple. I saw my surgery, I went and did visits and paperwork at lunchtime, I saw my surgery in the afternoon. Duty doctor was usually manageable in the time you had for it. Now most days feel like we're fighting fire. We never have enough capacity. It's so much more complicated now offering primary care than it was even 20 years ago. We see so many more people that would have previously been seen in the hospital. We have now lots of people on waiting lists for hospital treatment that may not be delivered for 2 years, so they keep coming back to us. We've already talked about the loss of community services. So again, we see those patients. Our patients are getting older. We've got quite a lot of patients in their late 90s, over 100. They're more complicated. There's lots more things we can do for them, but it requires a more complicated level of care. And it's harder to deliver that in 10 minutes. We have just gone up to 15-minute appointments because it feels safer. But things have changed, and therefore a doctor's receptionist no longer just finds you an appointment. They're an integral part of our practice team. So we have some things initially that probably come to the surgery that shouldn't. So for example, we have a really good minor eye casualty service within this area. And if you have an eye problem, you should contact them. And we have 3 opticians in the area who offer same-day appointments. And that's quite a new service, only in the last 3 or 4 years, but it's much better than coming to see me for your eye infection. I don't have a slit lamp here at the surgery. I can't examine your eye as well. If it were me who had a problem with my eye, I would never dream of going to my doctors. I would always go to the optician because that's what they're trained to do. So there's the first case of making sure that the person who's coming in actually, that the doctors is the best place for them. Lots of things can be seen by other services, whether it's minor injuries, whether it's the pharmacist. Once people need to be seen within the practice, we have to remember there's a whole practice team. So the GPs are in charge of that whole practice team, but it's a team effort. So it may be that you need to see the practice nurse for that thing, or we have a advanced nurse practitioner, and we also have things that we've talked about before, the physio, the pharmacy. So again, that goes back to the care navigators, putting you in touch with the right person. Then if people do need to see a doctor, there's 2 things. There's same-day acute problems that actually really need to be seen that day, and that will be seen by the duty doctor, and we all rotate being the duty doctor, so you won't get to see the doctor of your choice on that day, and it's not necessary, and it's an acute problem. It doesn't matter whether they've seen you before, and that could be anything from an ear infection, a chest infection, acute appendicitis, mental health crisis. It doesn't really matter. They will have access to all your notes. All the notes are on the computer. We all have access to them. But that's, you just have to see whoever the duty doctor is on that day. And the final group are really important. Those are the people with long-term conditions, and they are the people that you might have been the doctor for 20, 30, 40 years, and you've built up a relationship with them for a long time. We try to make sure that patients can see the doctor of their choice. As I've said here, the appointment time for a routine appointment is about 2 weeks, but it can be longer if you want to see a specific doctor. So if it's follow-up of your long-term condition and you want to see that specific doctor, I go back again to what I said at the beginning, booking those appointments in advance. We will always try and do our best. Most doctors now don't work full-time, partly because the demands of the job have now become so much. It's quite hard to do it every single day. Because without causing burnout and people leaving earlier. And often doctors have also developed other more specialist skills. So we have doctors in the practice who are GPs with a special interest in dermatology, which is skin. We have doctors in the practice who are GPs with a special interest in MSK, musculoskeletal medicine. We have doctors that are training doctors, so they run the training schemes for newly qualified doctors who are training them to become GPs. They also run the training for medical students. So we are all involved in other things. So we try our best. Patients usually get what they want. but it's not always possible. If people are going on holiday as clinicians, we tend to hand over to somebody else. So we always know of issues that are coming up, and we've been fully briefed by the doctor that you may have been seeing long term. I think we're small enough that people can access us in the way that feels most appropriate for them. It is a general worry, I think, in life that there is a lot of people who are missing out on the things that happen digitally. So there's a lot of time you go to shops now who don't take cash payments. And for me, that's perfect. I pay on Apple Pay and I only need to take my phone with me. My mother-in-law, who's 92, who's amazing and very bright and active, doesn't use the internet at all, and therefore she has cash, and that's a bit of a problem. It is something that across the board in Bradford District and Craven we are addressing, but there are an element of the population who aren't interested, who they don't want to use access. It's not a case of being taught, it's just they don't want to be a part of that. So we have, if people have specific access requirements, so we have some people who've got language issues because they've had a stroke and they've lost the ability to communicate, we have that written in their records so that we can be really clear, we know what to do with them. We've got some patients who are very deaf, so they have to come in the practice, or we have to just go and visit them at home. So there are ways round it for specific issues, but we tend to just let people contact us in the way that's most appropriate for them. If people want an appointment on that day, we do tend to telephone all those people first once they've got onto the doctor list, partly so we can deal with some of it on the phone, partly because we might need to bring them down earlier, we might need a little bit more information, and that can occasionally be a problem if people struggle with access to the phone, but usually they are people we've flagged up early and we already have plans in place for them. I think over the last few years, since the last contract came out in 2019, I think primary care and general practice has changed because that is the wish of the government, and I feel that sometimes nobody told the patient. So because we've got a lack of staff in primary care, so a shortage of general practitioners, a shortage of practice nurses, there's no immediate way to address that overnight. There have been many answers where politicians have promised an extra 5,000, 6,000 GPs, and obviously they take a long time to train and they haven't really been forthcoming. So the government has invested quite a large amount of money in what we call R's roles. So they're additional roles that we have in general practice. So things like we talked about, like physios, pharmacists, mental health coaches, social prescribers, and they perform a really integral role within our practice. But I do think there hasn't been great communication with patients to explain that these are really trusted members of our team, and we're starting to deliver general practice more as a team approach rather than just an individual doctor-patient relationship. I'm not saying this is better or worse than what we had before, but it is definitely different. COVID added to that. There were extreme pressures put upon primary care in COVID, both for keeping the staff safe, but keeping the patients safe as well, and trying to deliver some routine-based care in the middle of an international crisis. And so I think a lot has changed since 2019, and I think a lot of patients feel very caught on the hop. They feel that they're not aware of what's going on and why isn't it working like it was before, and patients always say, when are you going to go back to normal? But I think actually this is the new normal. This is the way we have to deliver primary care now because we don't have the staff to deliver it in the way that we used to. The demand has gone up, patients are more complicated, all the things we've already talked about. And I think there has been a lack of information explaining that to patients about what to expect, and this is what's happening, and I think that a part of that has led to the dissatisfaction that people have had with primary care.